How cool would it be if you can go to sleep and in 26 weeks have a reduction of 40 centimeters squared from your visceral fat? What does that mean? It means that your body will preferentially burn off the fat around your organs, midsection, all the places we don't want it. This sounds too good to be true. It's actually an FDA-approved peptide therapy called tesamorelin, and it's some of the best data we have for peptide therapies in adults. So let's dive in. First though, I'm Dr. Alex Watson, and I get people ready. By that I mean I get people ready for surgeries, cancer therapies, performance-based things like fitness competitions, and just general wellness. So the reason why that the measurement here is in 40 centimeters squared, that's in relation to the general recommendation of under 100. So you're bringing that down by something in the same order of magnitude here. It's actually a meaningful improvement, but it's not without its risks. We'll get to those in a minute. So this belongs to a class of peptides called growth hormone releasing hormone analogs. The related ones in the class, like sermorelin, ipamorelin, and CJC1295, all fit in the same way. Each one improves the brain's release of growth hormone. These are just one set of tools in our toolbox, and we have a number of other ones that can complement these potentially to improve body composition, some you've heard of, and some that are a bit more cutting edge. I need to point out, first and foremost, like always, that this is not medical advice. A lot of these peptides are not FDA approved for these purposes, or any purpose for that matter, so definitely do not try any of this at home. At least not without the guidance of a trained physician and access to peptides that you trust. And even so, any sort of exploration of these will very much depend upon your risk tolerance and general health background under the guidance of a physician. All right, before we get started though, so if you really are interested in these things and are curious which ones may be best for you and your goals and your health history, go to peptides.admiremedical.com. We built this really cool form that you punch in all your goals, your age, your medications, your medical history, and it suggests different peptides for where you can start your research and kind of take it from there. It also includes different hormonal assessment tests. So for menopausal women, there's the green scale, so you can see how severe or not menopause symptoms are on the standardized scale. Or for men, we have the ADAM questionnaire, so you can tell do you meet criteria for further testosterone level testing. All right, let's move on. Other ones that we're going to be talking about today that are related are AOD 9604. That one is a growth hormone fragment, essentially. It's related to growth hormone, but the idea is that it targets specifically certain tissues and avoids others to minimize some of the risks associated with more long-chain growth hormone. In the same family of these is IGF-1 LR3, colloquially termed rocket fuel here, because it can act directly on muscle tissue to strongly stimulate anabolic potential here, so muscle growth. All right, I don't love the term biohackers, but everyone knows what it means, so we're going to go with that one here. Why should folks that are interested in manipulating biology really be focused on peptides? Well, the reason why is that in some cases you kind of max out what the normal physiologic potential is, and if you can pull some levers here on certain hormones that we know have both fat burning and muscle building benefits, the downstream effects on metabolism and general health could come from that as well. We also know that some of these hormones are going to decrease with age, so growth hormone decreases as we age. That is one relationship with cognitive decline here. We're going to talk about that in another episode coming up on dementia prevention. One strategy with these is to try and mimic the normal circadian rhythm of growth hormone. So if you can give it before bedtime, you can elongate and exaggerate the pulse that we normally have when we're sleeping to improve deep sleep quality, restorativeness, all that stuff. The counter argument is that we have multiple pulses throughout the day, and so if you can raise the floor on all of those, then you may get overall better recovery throughout the day and get the benefits across the board. However, whenever you exaggerate physiology like that, then you theoretically raise the side effect concerns of worsened blood sugar, which we do see with tesamorelin, as well as any theoretical cancer risk, because if you're stimulating growth, you're stimulating growth of cells you may not want to be stimulating as well. So in general, today's goal is to go through all of these, put them in context, share the known risks, theoretical risks, and benefits, and put it in context for everyone's different risk tolerance so that you can make a better informed decision if you are going to pursue these on your own. I'll say it again, under the guidance of a trained physician or other medical professional for these ones. All right, so real quick biochemistry, just so we can understand things in the same terms. The normal axis here of production is your hypothalamus releases growth hormone releasing hormone, and what that does is it then tells the pituitary to release growth hormone when you're sleeping or throughout the day as well. Based on that, when growth hormone hits the liver, that stimulates the production of IGF-1. So we're typically measuring IGF-1 when we're looking at growth hormone activity because growth hormone is tough to measure in the body. It's very short acting. Whereas IGF-1 has a much longer half-life, and so we can really detect the upstream effects by looking at IGF-1 levels. IGF-1 then binds to different tissues in muscle and fat cells to do all the things we've been saying so far: build muscle, burn fat. The reason why it affects blood sugar, though, is that's part of the reason why it's released at nighttime, because you're fasting. The inverse of that is also true, where a lot of times when you're taking these peptides, you do not want to take them with any sort of a carb-rich meal, because you're going to increase the counter hormone, somatostatin, which will then kind of impede release of growth hormone there. So there's a way to do this and improve the potential response to these things, even without more peptides, more drugs, anything like that. So as I hinted at before, AOD 9604, that essentially can be very far downstream of this whole process and act directly on the fat cells and not really anywhere else. So you may theoretically minimize any sort of negative effects because you're targeting the ideal tissues a lot more and avoiding some of the ones that may be collateral damage or collateral worsening here, offstream targets. Whereas IGF-1 LR3, that kind of just skips the whole process. So instead of giving a growth hormone releasing hormone analog like the Morlins or CJC, this is even further downstream and is directly acting on certain tissues like the muscles. So the idea here with AOD 9604, I'm going to start saying AOD, it's a lot easier, is that with that shortened fragment, it maintains that fat burning potential, binds to fat tissue, but doesn't have any sort of impact on liver expression of IGF-1, therefore no issues with blood sugar or insulin resistance, which we do end up seeing if someone's on, say, growth hormone directly over time. You will get insulin resistant, blood sugar issues, and that's why there's some trials of longevity before that paired it with metformin to oppose that action in the liver. Kind of cool little biohacking. In one study with AOD, there was a significant improvement in fat loss, not dramatic though. Instead of almost a kilogram in the placebo group, it was 2.8 kilograms over 12 weeks. And if nothing else was done, there's always the argument of, is it going to synergize well with other therapies or with other activities, such as increasing strength training, certain zone 2 styles of aerobic training. Maybe it does enhance that benefit. We just don't have the research to say so. But in this case, there's going to be a lot of theory to this stuff. But again, the big finding here is it did not raise IGF-1 levels nor worsen insulin resistance. So it truly bypasses the liver in this case, and all the potential negatives with that one. All right. So besides that 40 centimeter squared loss of visceral fat, the actual point of this is that it improves metabolic health. So even though one of the side effects is worsening blood sugars, it is just during that treatment, because in the long run, if you're able to maintain that fat loss, you're going to maintain better metabolic health in general, most likely, because, as we see, reduced triglycerides. Triglycerides end up getting wedged in fat tissue, which then worsens the insulin receptor sensitivity. Jargon speak for saying that if you lower triglycerides, you're going to improve your blood sugar control. So essentially the opposite of what we see when you're on tesamorelin. And the big piece here is the liver fat reduction as well. So that ends up being kind of a runaway train in some cases, where fatty liver disease worsens triglyceride levels, which worsens that muscle's ability to take up blood sugar, which then worsens fatty liver disease because the liver is running out of places to put excess blood sugar. And if you can break that cycle, then the opposite virtuous cycle can happen. That's always kind of the goal with these things. It makes it so that you can have a sustainable benefit even when you wean off of the peptide, theoretically, because you've broken that self-propagating vicious cycle that worsens weight gain and worsens metabolic syndrome and all those sorts of things. And if you add ipamorelin to tesamorelin, it has a slightly different mechanism here, and it binds to a different receptor in the brain that also releases growth hormone. So you get the synergy between that to further raise the growth hormone peak, and in doing so, the difference between these medications and taking growth hormone directly is there's actually more than one growth hormone, which is kind of the idea between AOD, is that it's essentially a fragment of that. And our brain releases multiple different types of growth hormones that have different activities in our bodies. So if you can complement these and potentiate the release of the whole family of them, then you may get better benefits in terms of muscle building, fat burning, all that good stuff. Epimorelin tends to be shorter acting as well, so you kind of maintain that normal physiology and just get a nice potent release of growth hormone. This is all depending on your risk tolerance, because there are those theoretical risks that I hinted at before, we'll get into later, and you want to make sure that you're doing these things knowing that you want to mitigate any potential downsides here. So if you're doing these things to improve your metabolic health, theoretically you're going to improve some of those theoretical cancer risks, because metabolic health is a direct contributor to cancer risk. Talked about this in our cancer rehabilitation series. So if you can improve those things, it's hard to say. No one's done the study to determine the trade-off here, improve metabolic health versus any sort of tumor stimulation of growth hormone, which one wins. But if it's a short course of one of these versus a longer term of improved metabolic health, then it could be a pretty big net positive here, especially if you're going to add more muscle mass in the process. So burning fat is one thing, but building muscle is another one, because muscle is just an insurance policy against all the negative effects of aging. Muscle releases anti-inflammatory molecules, it makes you just generally independent and resilient to falls and all that good stuff. So in the same way of the virtuous cycle of stopping that visceral fat, building muscle has its own virtuous cycle of keeping you active, keeping you engaged, keeping your brain healthy, all that stuff. So by kind of building up that muscle mass during a course of this stuff, well, then you can have a longer term benefit there well after these peptides are out of your system. This is not a true graph here. This is just one that AI kind of built together for me. So raise the floor here, because CJC, when it's part of a special complex, so CJC is often actually CJC DAC, and what that is it's essentially a molecule that keeps it active in the body longer. So by doing that, you get this whole week-long boost in your overall floor of growth hormone, and if you're adding epimorelin to it, you then increase the peaks of all these throughout the night. And it goes back to the prior point that if you can have a better sustained level higher, but still maintain some physiology, then you get that cyclicality that the body kind of likes. And when you raise the floor, you can improve your recovery, all the same things you're going for. So not that you have to earn these therapies at all, but I always, if someone's going to be doing these things, it's important to try and pair it with an increased training process or some other potent metabolic benefit that you can then just enhance with this kind of therapy. By itself, sure, it can be beneficial, but when you really boost the efficacy of strength training, all that kind of stuff, it's just that much more a potential health win. Okay, so some of the risks here are just related to what growth hormone can do, which is increase water retention. So that's where that the paresthesia, so it's compression of nerves, causes tingling and that kind of stuff. That's what the edema in there as well. There was a study involving CJC that was halted because a patient died. The available information suggests it had nothing to do with the peptide therapy, but we can't say that for sure because the reports are kind of sparse on this one. But with the number of people using this currently, if that were such a potent signal, you'd think that it would pop up again in the anecdotal reporting here. Also, that was a very specific patient population, so just like tesamorelin was studied in patients with HIV and the lipodystrophy that happens with that, so kind of fat deposition in places that it normally shouldn't be, so visceral fat. There was the same kind of study for this one here. And obviously, that kind of a population with certain medications may have a different risk profile than someone who's an athletic type who's trying to use these to enhance recovery as they're training for something. Just a kind of one-off vignette there. Back to the IGF-1 LR3. The idea here is that it is not bound up in the same way that native, so the IGF-1 that our body produces, doesn't get bound up to the same proteins that kind of decreases activity level. So by staying free, it has more chance for biological activity, and it gives it a longer half-life too. So we see about a 2 to 3 increase in the potency relative to IGF-1 for muscle benefits, and it circulates for over a day essentially. But as you can see, the best data we have are in rats on this one, so not the most compelling human data. We can definitely make inferences from this one, but goes back to this is on the further end of take the risk into your own hands here and make sure someone's watching you and drawing labs and that kind of stuff if you're going to even entertain using this peptide for these purposes. However, the study compared chronic steroid use here in the rats of dexamethasone, which very, very potently can impair muscle mass. So I was able to actually improve the nitrogen balance, so the anabolic ability, so the muscle's ability to take protein and build muscle out of that. Now, because IGF-1 acts on the muscle to kind of promote that growth, we do see this risk of hypoglycemic episodes. So low blood sugar, that can happen because muscles are largest depot for blood sugar storage. So if you're going to increase its kind of thirst for nutrients and whatnot, then you can just kind of draw a lot of that blood sugar out of the blood there. Now, we've hinted at it a couple times, and I'm having the red box here about the risk for cancer growth. So IGF-1 stands for insulin-like growth factor. It makes things grow. And in doing so, cancer cells have receptors for growth hormone and IGF-1 in this case. And so you do run this risk of stimulating tumor cells. Now, we don't see this in all of the peptides in this growth hormone family here. There was a study with Sermorelin in individuals after brain tumor resection that resulted in growth hormone deficiency, and there was no increased incidence of brain tumor recurrence. So theoretically, if there was going to be an increased risk of cancer, you'd think it would be in folks who had already had it, but we didn't see that. But that was in Sermorelin, which is a very, very different potency level than most of the rest of these here. It's often kind of regarded as like the intro peptide in this family because it's certainly increased the release of growth hormone, but not nearly to the same extent. It maintains it within normal range here, just the top end of the range, whereas some of the other ones will kind of blow the roof off that one. Speaking of, so the idea here is that if you're going to increase growth hormone levels, you get the benefits of growth and the other stuff that it does. So there's a reason why these are going to pop up again in the dementia prevention lecture that I have coming next, because growth hormone is one of the main growth hormones in the brain, and we see declining levels as we age. Now, does brain aging happen because of declining growth hormone levels, or do declining growth hormone levels happen because of brain aging? Yes, probably both. But there's some variable here in terms of sleep quality. So when you increase growth hormone, you increase deep sleep, and we see that here with Sermorelin, with that increase of 18 minutes there of deep sleep on actual sleep studies of patients using this medication. And even though some of the more seasoned peptide folks will kind of roll their eyes at using Sermorelin, it has a meaningful impact. It increases that pulse of growth hormone pretty significantly, as you can see, as well as the downstream effects of IGF-1. And we see that lasting IGF-1 for weeks after you stop Sermorelin. So it is a meaningful increase. One thing I've noticed clinically, and it doesn't pop up in the research, but I've seen it enough times that I'm kind of suspicious, where the issue some folks have with Sermorelin is that it's a dirty peptide. It doesn't only act on growth hormone. It increases other hormones in the brain, including ACTH, which is the upstream of cortisol, so it may affect REM sleep, but also LH. And what luteinizing hormone does is it increases your body's production of testosterone for men. So you would think that's the case, that testosterone levels will go up. And there were some papers on this that didn't really show it, but I'm wondering if there are certain people that are just more susceptible to it than others. Maybe it's someone who had lower LH to begin with. They're more sensitive to any sort of rise in that, because I've seen this a couple times where I've prescribed only Sermorelin to a patient. No testosterone-related products, no enclomiphene, nothing like that. And 3 months later, their total testosterone was up a couple hundred points, and their luteinizing hormone was up a couple points too. So it's pretty good causality there. But we could also say, is it from the improved deep sleep that's raising their LH and their testosterone? It's tough to disentangle that. But I definitely do not see this commonly, but I've seen it enough times that it's given me kind of a, maybe this actually happens kind of thought. Yeah. And mentioned here again, no glycemic drift, so no issues with blood sugar, and it's generally very well tolerated, minus that potential worsening of REM sleep. In the short term, I've noticed anecdotally just improved sleep continuity, general feeling of refreshed, but after a while, it seems that there is some waking up early effect, and that may be that REM sleep blunting effect. So theoretically, if you're someone who has issues with REM sleeps, either night terrors or potentially something like sleep apnea, you may lean into this and really get the kind of fringe benefit out of that and make lemonade out of lemons here, but this is getting kind of in the theoretical weeds. All right, so other body composition type peptides, gonadorelin. And what that is it is a analog of the hormone, if you remember LH a couple minutes ago, it is upstream from that one. Just like growth hormone increases IGF-1 and GHRH increases growth hormone, LH increases testosterone in men, and GnRH pulse increases the LH pulse. So gonadorelin then mimics that, increases LH, increases testosterone. It also increases FSH release. So in the same way that, say, clomiphene or enclomiphene can increase fertility by raising those two hormones, gonadorelin can do the same thing, or it can be used if someone's been taking testosterone long enough or high enough doses that they've suppressed their natural production. They need to wake that system back up. In the gym parlance, this is PCT, post-cycle therapy. Gonadorelin can be effective for that as well. And the beauty of using this versus testosterone therapy, it's kind of like using HCG in the same way, in that it increases testosterone levels by stimulating production, not suppressing it temporarily because you're getting external testosterone. And I'm going a little quickly here because I don't want to drown you in details, just kind of paint a picture of how we think about some of these things here. Here's kind of a sample of a way to approach this. What you may do in different phases of training or different strategies or different concerns. So if your biggest concern here is someone who's metabolically unhealthy, very central weight deposition, you may be looking more towards tesamorelin and kind of pair that with ipamorelin or something else to just get that synergy there between the two. And that will give you a nice bigger impact on visceral fat loss. So you can potentially get that longer term benefit of reversing the vicious cycle here, getting the flywheel moving in the right direction. Also got some labs on here that you might want to monitor in these cases. With tesamorelin in particular, you're really going to be monitoring different measures of glucose control. So fasting glucose, A1C is not on that one, it's on the next line, but it would be meaningful as well, or fructosamine, different measures of kind of an average of your general blood sugar levels. If you want to monitor the effect, IGF-1, get that in the morning. If you're moving down to recovery or cutting phase, so much more of someone who's not starting at a metabolically unhealthy spot, but instead a well-trained individual, then you may do something along the lines of CJC, DAC with samorelin. It's often actually paired with ipamorelin instead for a little cleaner of that growth hormone push, because ipamorelin, because of the way it works, doesn't have that dirty activity that we talked about with samorelin. It's really going to focus mostly on that growth hormone effect, and so you can get what you're going for if you really just want that growth hormone. Okay. And if you're really going for to really supercharge that fat loss, you could pepper in AOD in this one, just because it's going to give you much more of the metabolic benefit, the fat loss benefit, without increasing that burden of extra growth hormone circulating and the potential negatives we've talked about several times now. So it's a nice way of doing that, but you're just, anytime you add these peptides, you're just further increasing the risks here of potentially, a contaminant or a reaction on your part, because these are proteins. Proteins can stimulate an allergic reaction, even though a lot of these are very similar to the ones that we have in our bodies, so theoretically lower risk. And we kind of do see that in the research. It's still not impossible. And in general, anytime you're looking at any of these, plan on taking any of them, the baseline risk assessment is going to involve screening for cancer, of course. So age-appropriate cancer screenings are really important. So PSA is on here on the bottom one, but really, I order a PSA, and if they're at higher risk or anything, maybe colonoscopy type screening. So if that's indicated, we can get that. And then we're also going to look at indirect measures of metabolic health here, so cholesterol panel, that kind of stuff too. Alrighty. So here are the concerns. We've touched on a lot of these already. I just kind of went through a lot of them with the oncology side of things. But the big reasons to work with someone who knows what they're doing, as well as know your source, falls into a couple of these here. One, there's going to be a risk of people cutting corners because of the FDA's kind of undulating category 2 list of what's allowed, what's not allowed, what's gray area, what's PNG on this one. So because of that, You may have some of the larger scale compounding pharmacies just saying, I don't, you want to get near this, this is not worth it. And instead you have kind of, we joke, bathtub peptide production. Metaphorically, someone is making these things in their bathroom and putting it into a vial they just kind of wipe clean with a damp cloth kind of thing here. So in all seriousness, when they have done independent assessments of some of the peptides on the market, you pick up trace LPS. LPS stands for lipopolysaccharide, and what that is, it's a fragment that is very, very inflammatory. It stimulates our immune system because it is in bacterial cell walls and everything like that, or membranes. I always forget which one's which in this case. Basically, fragments of bacteria, and so the body, you're not going to feel that refreshed feeling from the Morlin here if your immune system is revved up because it thinks that you're injecting yourself with bacteria. And so that's why it's really important to get these from a compounding pharmacy that you know and trust, and you know the source, because then you have a much better confidence in the total purity of everything here versus some of the online research chemical sites, or you get off Alibaba and good heavens, you have no idea what you're injecting into yourself here. Because as I've stressed in several advertisements and other of these here, you have to inject these into your body. And the other piece too is if you're competing in anything that's going to be tested, so the World Anti-Doping Association, or even certain powerlifting competitions or other competitions like that, in the tested classes, this stuff pops up, and it would be unethical anyway. However, if you're joining that enhanced games, this is also a story that I like to tell too, is because the potential here with these and some of the other ones is much better recovery that you might have had 10, 20 years ago. And so all of a sudden world records are being broken by retired athletes. Like, that's a pretty big deal and says a lot about the potential of some of these things here. So, and for someone trying to kind of skirt these rules and say, hey, maybe there's a way around this stuff, if they're using LCMS, so mass spec, they can pick up trace amounts. So just because a lot of these are non-native peptides, if there's any amount still hanging around the body, there's a strong chance that it's going to show up on that test. So now in terms of just general risk reduction, as I started this whole thing out with, if you're going to mirror physiology in terms of that circadian rhythm of growth hormone, theoretically probably has a lower risk of all that cancer stimulating stuff than you would of something that's going to chronically elevate it when you get into your LR3 or your CJC, or tesamorelin has a longer half-life as well. So that's why personally I've used samorelin and ipamorelin are more of my personal flavor, just given my risk tolerance and just what I've been blessed with genetically in terms of the relative lack of assistance that I've needed to maintain general health here. But for someone who just was dealt the poor hand of metabolic inheritance here, everyone's risk tolerance is different, and it's an apples to oranges comparison here. So my job as a physician is just help my patients understand those risks and say, here's what we know, here's what we don't know, here's what we know about your personal risk. How do you feel about all that? Alrighty. Key takeaways. So, the foundation here is understanding that growth hormone is not one hormone, it's many hormones. And so when you add in different ways of kind of affecting all those different pathways, you can get different effects from different peptides that are all growth hormone releasing hormone analogs. So different things that you'd think should all have the same effect, well, if they tell the body to release a different kind of balance of these different types of growth hormones, then that's why tesamorelin may have a better impact on visceral fat loss versus other peptides that have a more balanced impact on fat and muscle and these sorts of things. So having a little understanding of that general biochemistry can help you better target your goals here with specific peptides, so that not everyone in my practice has similar goals, the same peptide kind of programs. We want to make sure we're tailoring this perfectly to someone's body composition, training status, genetic history, age, that kind of stuff. And then it just goes with your confidence in terms of the studies. So if you're someone who is risk averse, then go with the ones that have been or are currently FDA approved. if any at all, of course. So, tesamorelin is better studied than IGF-1 LR3. Even CJC, not quite as well studied either. So if you're going to want to minimize your risk here and those sorts of things, you may want to go with one that has been more rigorously studied and in populations that may be at higher risk than you. So if the higher risk populations don't have some of the negative effects that you're worried about, then you may, with counsel from a medical professional here, feel safer in certain peptide therapies. All right, so we kind of made the point here. These different peptides can have really beneficial effects on recovery, sleep, muscle growth, fat burning, all that stuff, and picking the right kind of constellation of them can better target your goals. The next ones that we're going to talk about here are going to be healing and recovery specifically, so injury healing, general inflammation, that kind of stuff, where a lot of these will pop up again too, as well as dementia prevention, because dementia is going to be a similar plane of attack in terms of growth hormone signaling up here, as well as better metabolic benefits. However, there are some peptides specifically that are going to be uniquely beneficial for brain health and those sorts of things. But we will get into those soon. All right, so thanks for looking at all this stuff. And again, if you want to check out peptides.admiremedical.com, you can see how your goals line up with some of these or other peptides that are out there, as well as you can schedule an appointment to talk with me about these things and we can really go over it together. Licensed in 22 states. They're listed on the website there too. But overall, this is a really interesting area for medicine, very person dependent, and you definitely do not want to do this on your own. You should really be working with a physician. Not saying it has to be me, but just saying that you want to have someone who knows your personal history better, guiding you through these sorts of decisions and the available research or lack thereof.